We move now to tertiary mental health services, and I'm very pleased to welcome Claire Murdoch, who is our National Mental Health Director, and Stephen Fern, who is the programme lead for this programme, to join us at the table. I'm going to invite Sir Bruce Keogh, our National Medical Director, to introduce the paper. Bruce.
Thank you, Chairman. And firstly, can I add that it's a privilege to work with Claire and Stephen. Both of them have an accomplished track record as successful chief executives of significant mental health organisations. So their expertise in helping us move mental health forward is very, very welcome in the organisation. So thank you for that. One of the issues that we have to address is that mental health services for young people are afflicted by fragmentation. Fragmentation of geography, fragmentation of care, and that in turn is related in some ways to fragmented funding and accountability. So this paper that Claire and Stephen will talk about reports a proposal from our chief executive to address these issues through what might be described as a modest proof of concept initiative, where secondary mental health volunteer trusts will manage tertiary services. So on that note, can I hand over to Claire, please?
Well, thank you very much, Bruce. And can I say it's a real privilege to be at my first NHS England board meeting, probably some 100 days in post there or thereabouts. Before handing over to Stephen Fern, who'll talk about the particular paper in front of us, I'm hoping to take the liberty to very briefly, in a few brief moments, remind the board of the context within which this particular programme of work is landing for mental health. So the board will remember that NHS England commissioned an independent task force to report on our mental health, England's mental health, and that reported in February of this year and made 58 cross-government recommendations to improve England's mental health. In July of this year, we in NHS England published our implementation plan, which I think it's fair to say was full of muscle in terms of the amount of detail it gave around who we'll be treating, when we'll be treating them, where the money will flow. And in a nutshell, our aspiration is to provide better access to evidence-based treatment for an additional 1 million people, and by investing an additional £1 billion. And the action plan that we've published, the 5-year forward view implementation plan, captures the detail of that. Our plan has various work programmes across the life course affecting and changing mental health across the health system, in acute settings, in primary care, in the community. It is also a plan designed to deliver better outcomes across diverse populations, and it's a plan designed to improve the integration of physical and mental health, treating the whole person. Let's stop some of these silos. We then have been working with the STPs on ensuring that our plan is manifest in their proposals, and we were delighted when on the 22nd of September we were able to secure, NHS England was able to secure really considerable space in the planning guidance for the implementation of the plan. So these are all things that we've put in place to absolutely help the system drive the delivery of an ambitious agenda. Just to very quickly, I'm not going to, and much as I would love to, there isn't time, but I'd just like to give the board a flavour of, if I might, some of the work that's ongoing already around different programmes, very, very briefly. So, for example, at the moment, we've just issued a call for bids to providers to extend our talking therapies. Last year we saw 900,000 people in England for talking therapies, and we have a plan to see 600,000 more, in particularly focusing on those living with chronic and complex physical health problems who will benefit from psychological therapies. It's also part of our plan to deliver 3,000 more therapists in primary care. We will be announcing very, very soon soon where our first wave pilots of this next push will be. Another example of work that's ongoing at the moment is that we are about to announce, identify and then announce, pilot sites for delivering new models of perinatal care. This will be an announcement we'll be making shortly. We gave a commitment to see 30,000 more women by 2021 who are suffering from, perinatal conditions. So that will be happening really soon. 30,000 more women. We're just finalising plans to identify where we will be setting up 4 new mother and baby units across the country, linked to our community push. Last week, we announced the release of £25 million to assist with the waiting time targets, capability and capacity in child and adolescent mental health services. We've seen an additional £149 million going into the baselines this year of CCGs to treat more children, remembering that our aim is to treat 70,000 more children and young people by 2021. So we've released an additional 25,000 to help with some of the waiting lists and pressures of the here and now. And next year we're releasing a further 170 million to help with those plans. And I'm nearly at the end of where this piece fits in, but just another example or two, if I might. We will in the short term be opening some more CAMS Tier 4 beds. We know that there's a pressure in the system now, but it's not national, it's in certain areas. That work's well underway, and next month, October, we'll know where we need to place additional capacity into the system. And finally, for example, we have recently put an additional £5 million into the urgent and emergency care vanguards to look at crisis and emergency treatment for children and young people. We're doing so much more than that. Read the implementation plan and the planning guidance. But I just wanted to give the board a flavour of the tremendous work programme that's underway around the 5-year forward view for mental health. And at that point, I'd like to hand over to Stephen, who's been working with colleagues in specialist commissioning and the mental health team around a very exciting programme of work in terms of new models of care. Thank you.
Thank you, Claire. Thank you, Chair. So for the last 5 months, I've been leading this programme. Prior to that, I was Chief Executive of a mental health trust for 14 years. And I recall that on numerous occasions, we had to place acutely disturbed young people in private placement out of area many miles from home. Yet local clinicians told me this could have been avoided if we'd had in place local crisis and home treatment services for young people, which exist in some parts of the country, but not all. So that's an example of the type of service gap this programme is hoping to address. And if I give you a specific example, in the paper, Tees, Esk and Wear Valley FT, they're one of the proposed sites. They calculate that within the first 12 months, they could reduce occupied bed days out of area by about 3,500, which would generate savings which would be more than enough to develop a local crisis and home treatment team for young children. So what we're doing in essence is taking money that we're already spending and reinvesting savings from that in local services to provide better care. So I hope that gives a sense of what this programme's about and why we've established it. Just a few headlines on where we've got to so far. So a call for applications went to every provider of tertiary mental health services in the country, including public sector, NHS, private sector and the charitable sector. Fantastic response. 36 sites, partnerships applied to be part of the programme, which represented over 100 providers. We've selected 6 sites, which again include the public, charitable and private sector, and you'll see those 6 sites in your paper. Each of those have agreed to establish shadow arrangements from the 1st of October, which will enable us to work with them to develop full business cases by the 23rd of December, which will be robustly lay out over the next 2 years their plans to reduce occupied bed days, develop local services, generate savings and reinvest in things for young people and adults. So subject to appropriate due diligence and agreeing risk shares with those business cases, we plan to transfer care budgets to those providers from the 1st of April 2017 to give them the levers and the incentives to deliver this better care closer to home. I'll pause there, Chair.
Stephen, thank you very much. Let me open it up now to my colleagues. Victor.
This is to be welcomed. I mean, it's, we're hardly going to sit around here and slag it off, but I think that I think the out of area stuff has been it's been a wicked problem for a long time. I'm curious about your ambition for it, because I think we have to go for this in a very we spend a lot of money on this, and it's actually driven a market in poor market management, if you see what I mean. I'm interested in that and what your ambition is for this. Claire, me and you sat on the review of the police response to mental health in London, and we looked at some pretty shocking cases of not very good crisis management, which wasn't necessarily about the police, but about the NHS. And what I'm curious about is, as a result of where we've got to in the whole sort of mental health, what can an individual in crisis expect to receive that's better as a result of where we've got to in the sort of delivery of the new mental health care plans? I mean, what can someone in crisis expect that's different?
Are you talking about in the context of the broader plan, or what will our new care models
in the broader
bring?
plan. So my question to you is basically, what's your ambition for the out of area placements? Where can we go with this? My question to Claire is, okay, so what can an individual in crisis expect? Because that's at the point of most risk, isn't it?
Stephen, you first.
Okay, well, the ambition is that if we do approve these business cases, we will be transferring around £320 million of expenditure to those 6 sites. I expect, one of the principles is that they will take 100% risk on that expenditure. They all recognise that and will build that into their business plans. And they all, at this stage, are confident that they could make significant savings, stressing that the savings come from the better care closer to home. So obviously we need to work through the detail in the business plans, but in all 6 of those sites, I would expect to see robust new community services delivering care to people who were previously placed out of area. And I would be very disappointed if their cumulative downside cases did not add up to in the tens of millions from that £320 million budget. I'll obviously be able to confirm that more come December. There is then the consideration about whether we want to roll this out further into a second wave. There's certainly lots of people queuing up who are interested, but we haven't made a final decision about that at this stage.
The question about why wouldn't we actually?
Yeah.
Well, indeed.
I think it is. Yes. I tried to give the board just a snapshot of some of the work we're doing, and actually I would love to make the offer of a seminar or something to help the board see the whole programme and where we are. If, Sir Malcolm, you thought at the right time that would be helpful, it's something we'd be delighted to do. But briefly, some things I didn't mention. The plan's really clear about our ambition to reduce out-of-area treatments for people in crisis across the age range. In order to do that, you need a whole system to be working better. So the first thing I would say about, in answer to your question about crisis, is it's really important we're working cross-government with housing, education and local authorities, because we know the things, and you know better than, or as well as I, the things that can precipitate crisis are often gaps in social care or problems with broader life. So the first thing I would say is our NHSEngland priorities sit firmly within that broader cross-government push to better mental health. But the kinds of things that we more specifically are focusing on in the plan that we anticipate will help individuals who do find themselves in crisis is the plan is very clear about better access to liaison services. We're saying by 2021 we'll have crisis liaison services in all major hospitals across the country, for example. We're investing more and developing the capability and capacity of home treatment teams so that we can deliver more crisis care to adults at home or closer to home as well. We're doing considerable work on places of safety and Section 136, which was one of the major focuses of our work in London all that while ago. So the plan is actually very focused on adults, the whole pathway, how to prevent crisis, enable people to live well, but when they are in crisis, to make sure we've got the beds, we're not sending them out of area, we're making that pathway work through better liaison, better home treatment for people in crisis. And of course, one knows it's not just the partnership work that helps avoid crisis, it's better working with individuals around their plans and relapse prevention. So that is all in our implementation plan.
Thank you, Claire. Myra?
Thanks, Malcolm. Likewise, very positively view this paper, very welcome. I just wanted to ask, Claire referred to, the current problems aren't universally evenly spread. Some places are worse than others. Some places are doing better than others. How does this selection of areas map on to the problem areas, as it were? Do you see what I mean?
Yes. Yes.
Because willing people are not necessarily the places that are most in need.
No. So if I might, because I would very much like Stephen to answer that, partly why I wanted to set the context of the broader work that we're doing around the 5-year forward view is that we are looking nationally about the work programmes we're taking forward, and we are identifying areas of greatest need, and we will be targeting additional support and focus to quality improvement in those areas. That wasn't the basis upon which Stephen and his team selected these pilot sites, because I can't emphasise enough the extent to which this really is new models of care, breaking considerable new ground. But perhaps you could say something about how you selected them and why.
Yes, well, the 6 we selected, they had to go through a shortlisting process and then a panel interview, which included clinical experts by experience, and people like myself who've run mental health services, because fundamental to this is that they have got the expertise and the clinical leadership to do this safely. We don't want to be we will not be bringing back people from out-of-area placements locally without being sure that they are good, safe, effective local services. So that was the number one criteria. And then secondly, we were looking for, once they were above that line, different sizes. So they range from around about 8 million in a single trust, which I've just referred to in Tees, Esk and Weir, to £105 million budget, which is the West Midlands, which is a partnership of a range of different trusts. So essentially, with the business cases, we'll be testing which model works best. They're all lead providers are all sound lead providers, so they don't have any big regulatory issues or financial issues, but inevitably some are stronger than others. But they're all above the line. The question will be, if we do roll out to a second wave, that we maintain the quality, I guess.
Chair, if I might also just add that one of the things I didn't say in the introduction, but I think is incredibly important to the question you ask, is the Chief Executive and the team here have been working together with myself and others on preparing to publish unprecedented levels of information about access, quality, performance and spend. Now, this publication is due very, very soon, and what it will do for the first time actually ever for mental health is show us what's happening CCG by CCG across the country in those domains. Now, this is very exciting, and it really is, talk about driving transparency. It's an incredible step forward. There is just one word of warning. We are publishing that formatively for the rest of this year. So it will be less than perfect and so on and so forth, but it will be in the public domain. By the 1st of April of next year, we hope to have a set of information in each of those domains which really lets us penetrate which parts of the country are delivering this plan, which parts are struggling, where we need to focus efforts. So we're very excited about that too. Outcomes will form a part of what we publish. And the other thing I will say is, and I had a meeting on this just this morning, is this is a suite of information that will grow. So what we will see will be the beginning, not the end.
John, Steve, can I speak on your word expertise? This is obviously a very specialised area of activity, even within psychiatry, which is a bit of a Cinderella specialty. When this rolls out to second wave, are we thinking about the training of staff to actually fill that second wave? Is there a danger that we might end up with a rollout that we can't actually find the expert staff to make it work?
Workforce issues are on our risk register. Yes, that's true. What I would say is all of the sites we've selected, and there was quite a number that we shortlisted but didn't select, are already providing these types of services. So in a way, I mean, I know it's been badged as new care models, but in a way what it really is establishing good, effective local community services that actually people are already familiar with. They do know how to do it. Of course, there is the challenge, however, of getting, as you say, those specialist people in what is already a subspecialty who are able to staff and lead those new services.
Like with health education, though, with those responsible for training in Royal College?
Yes, yes, that's something that we will need to do. We haven't done that formally thus far. I think we're in the stage where we're just getting into the detail, and by December, when we have the full business cases, it will map out exactly what the new services will look like, and we'll have a clearer view then of the range of staffing and the numbers. Thank you, it's a helpful prompt.
Or just to add, and just to really reiterate, across the whole of the mental health programme, workforce is a considerable issue. We're used to thinking, particularly in the current climate, that it's money, but actually it's workforce is the major issue here, and we're working very closely with Health Education England to scope not only the numbers of staff we need, but capabilities, training, and so on and so forth. And we're also creating new roles within that, so it's not all just about more of the same, but it's a major undertaking, an incredible piece of work. And one of my jobs, working with colleagues, is to enable people who are thinking about careers to understand that this mental health across the range of programmes is going to be a very, very rewarding career. We've got to make mental health an exciting and rewarding place to work, and it is, says someone who's worked in it for 33 years.
Claire, I had the pleasure and even excitement of spending a day with 250 commissioners and providers and people involved in this sector to look at the way that information and digital technologies are going to transform both self-care but also care in the community and care in the home. And this was a relatively unstructured event, but it was hugely attended. So it tells you there's a huge amount of innovation going on in this sector with some extraordinary results, actually. What are you going to do in the 6 pilots that you have to test out some of the new ways in which we can completely transform through technology and digital technology and information?
I think one of the obvious things that springs to mind at the moment, given that they will need to be assessing and developing assertive discharge arrangements for people placed hundreds of miles away, and often large numbers of them, is to use technology to facilitate that. So, for instance, telemedicine, so that case reviews, care programme approach meetings can take place in a robust way without having to have, say, a consultant psychiatrist from the southwest, for example, driving 250, 300 miles to see the patient. So that's one of the first clear ways. There's also obviously things like digital devices that people could and should be using, and the best trusts are, so that when they go and see people, they have all the information there with them. They can log into their patient information system, and they can complete their assessments in real time with that person and then send it back to base. So a couple of
I'd like to
examples
stay in
there.
touch with you around the results of the 6 Wave 1 pilots, because I
Yes.
think that could be incredibly interesting in terms of how we replicate that and scale it quickly,
Yes. Indeed, delighted.
if you're willing.
Thank you, Simon.
Well, I was just maybe finally just going to pick up on Victor's point around targeting and outcomes and measurement here, because I think it's worth noting that today, in fact, a very important piece of work by the National Centre for Social Research published the 7-yearly study of the prevalence of mental health problems and the extent to which the NHS is or isn't offering treatment for them. Good news being that compared with when they looked in 2007, the proportion of people with a common mental disorder getting treated by the NHS has gone up from 1 in 4 to 1 in 3. The bad news being that there are very sharp increases in the number of young women needing services. And when you standardise for need, it appears that adults between 35 and 54 are getting a good deal. White British origin individuals are getting a good deal, as in fact are women, but black potential service users are substantially undertreated across NHS mental health services. And I mean, that just reinforces what we've known for many years about race and mental health. But I think as we think about the implementation of the programme that Claire and Stephen have set out through every one of the modules that the programmes we're putting in place, we've got to kind of see it through the lens of unmet need and the kind of race issue in the mental health system as well. And today's survey results reinforce that.
Yes.
That's really good.
It's pretty stark.
Would it be appropriate just to do a very brief response to that, because I welcome that. Thank you, Simon. What we have already done, and this was part of the selection criteria, is ask each of the sites to be absolutely clear about how they will assess the patient cohort that they're anticipating to bring back for the whole range of protected characteristics. But particularly in the adult secure services, there is a large overrepresentation of people from BME communities, so they need to be clear that those local community services that they're setting up are culturally appropriate, and that's one of the things we'll be measuring them by.
Right, well, can I value, Bruce, thank you both, Claire and Stephen, for what I think has been a hugely enlightening session. What is so important for us as a board is to be able to track progress in an area where we've had a task force, we've got clear policies and strategies, but be able to follow it through. So let's do two things. One, if you would pick up on Noel's proposal for further conversations about the digital side. And secondly, if we can organise a further briefing for the board in a development session so that we can get a full grip, not just on progress to date, but on where this is going, and some of the bigger issues, including those which Simon has just shone a light on in his comments. I think that would be much appreciated. But thank you very much for coming today and educating us. Thank you.